Okay. A very good morning. First of all, I'd like to thank LifeNet and Via Ocia for the invitation. I am very happy to be here. I am Víctor Beltran from Universidad de la Frontera in Temuco, Chile. My presentation is entitled Modern Techniques of Microsurgical Extraction and Alveolar Preservation. First, I will focus my presentation on the use of endoscopy system in the dental alveolar surgery, mainly regarding intraoperative magnification techniques during dental extraction and socket preservation. Endoscopy has been used for decades as a supportive technique for directing minimally invasive oral surgical procedures, and in the latest years has been increasing use in the endoscopically assisted of oral microsurgery techniques, such as flapless implantology, apical microsurgery access, tooth extraction, especially in impacted tooth removal, sinus fluid elevation procedures, tunnel techniques for bone regeneration, and periimplantitis treatment access in combination with laser system, for example. The development of endoscopy system in the dental alveolar surgery in the latest years has been possible thanks to the work of specialized centers in different parts of the world. In this sense, Professor Tornes from the University of Bergen in Norway pioneered in introducing the use of the rigid endoscopy system as a support tool during oral surgery procedures, such as the enucleation of large cysts and others. On the other hand, Professor Engelke of the University of Göttingen, Germany, introduced the use of endoscopic system in combination with implantology procedures, such as maxillary sinus lift and during routinary implant site preparation. At the same time, Professor von Ack's group from Bern, Switzerland, started the use of rigid endoscope for apical surgery procedures, mainly as control method. In the later years, other groups, such as Professor Niachelis in Israel, have perfected a number of devices for application in neuroimplantology and endodontics. I had the honor of working with Professor Engelke for about 10 years in the field of endoscopy, minimally invasive oral and implant surgery. I completed my doctoral program under his supervision in Germany in the University of Göttingen, and we have continued collaborating in multiple projects and studies since then. Here we are together in the Center of Oral Microsurgery of the Department of Oral and Maxillofacial Surgery in Göttingen, Germany. By the 19th, the Göttingen group in Germany, led by Professor Engelke, perfected the use of endoscope for indication in oral implantology, especially in maxillary sinus floor elevation procedures. In this clinical report from the Engelke group in 2022, the use of a small rigid endoscope of 1.9 millimeter of diameter was described for intraoperative implant cavity assessment. The author described a new method for endoscopic visualization called super immersion endoscopy, which allowed in vivo observation of the implant site after the cleaning preparation. With this method, it was possible to detect intraoperative accidents such as floor of mouth perforation and other complications. In 2012, our group published a new approach for the same technique, but establishing a difference between two techniques, which are the following. First, a super immersion endoscopy technique, which refers to an intraoperative observation at a short distance from the surface, for example, the bone wall, using continuous immersion, which allow for a highly magnified observation of the area of interest, ranging up to 40x, for example. In this image of the left, for the instant, it is possible to differentiate an implant bed predominantly cortical with poor vascularization. In contrast, you can see here a predominantly vascularized bone structure. The second is a distant super endoscopy technique, through which we can perform simultaneous surgical maneuvers that allows a more global perspective of an area of interest from 4 to 5 millimeters, for example. This technique can be very useful to visualize root or cyst remains, among others. In this image with black arrows, it is possible to observe here the position of the alveolar nerve after a complex extraction of a second mandibular molar. Now, I'd like to talk a little bit about the instrument and working position for the microsurgery team members. Here, we can see the fully assessment endoscopic equipment. This is the camera connected to the optics, which is attachment to the support. Beside the support might be connected to a irrigation system here. And the light fiber is also directly connected to the optics. It is necessary to undergo some training in a special design phantom before performing an actual procedures in order to gain experience and in the use of this equipment. We have given several training courses on this technique and instrumentation with the support of the car store company from Germany. Unfortunately, due to COVID-19 pandemic restriction, it hasn't been possible to continue with this training course during the last 2 years. It is necessary, this is the equipment we generally use during our oral microsurgical procedures aided by endoscopy. For me, the telepack system is an extremely comfortable piece of equipment to use in the dental operating room. In this case, the tower includes a monitor, a keyboard, a xenon light source, and a camera system with a digital image processing module. The image can be saved as stills or video file for research or legal history, for example. This is the arsenal of different endoscopic rigid optics that can be used in the clinical routine. On the left side, there are the 2.7 millimeter and 1.9 millimeter optics without support. In the center, there are same optics coupled with support. On the right side, there is the super endoscopy system for a 1.9 millimeter with an integrated irrigation system. Here it is possible to see the Engelke telescope shield, to which we can attach an optic of 2.7 or 1.9 millimeter of diameter. The most used angle for intraocular examination are 30 and 70 degrees from the optics. Here you can see some of the instruments most frequently used in the intraocular examination with endoscopic support. Eventually, we need instruments of very small diameter that provide a good tactile response and are easy to maneuver. For example, periodontal probes, a Langer or Lucas Curettage, and a special mini forceps similar to ones used during otorhinolaryngological surgeries. Here, we can appreciate the entrance position of the endoscope. For the different, here, we can appreciate the entrance position of the endoscope, in this case, an endoscope of 2.7 millimeter in diameter, in order to allow an occlusal perspective of a minimal invasive access for the removal of a right inferior teeth molar in this patient. It is possible to observe that the operator is working with a piezoelectric tips on his dexterous hands while holding the endoscope coupled with the camera on the other hand. The assistant is tasked with suction, irrigation, and separation within the surgical field. As you can see, this particular patient is intubated for general anesthesia. And Here you can see the working position for the different members of the microsurgical team. The operator is on the right, holding the endoscopic assembly on the left hand, and with the right hand, he controls the manual instrument or the cutting equipment, such as piezosurgical devices or other hands devices, which can be positioned or localized under direct visualization of the video monitor, which must always be placed in counterclockwise position. The assistant on the left side of the picture here is positioned parallel to the operator and performs separation and suction function to allow for an image which is clean of pollution. Now I will describe the basic methods for endoscopic visualization in oral microsurgery and implantology. Particularly, we will discuss two main visualization techniques that allows for wide range of application in the clinical practice. In this example, a very small character has been selected, maybe 2 square millimeters, and each pixel dot might represent a size of 20 microns. In this context, we know that the diameter of the vascular canals or Folman foramens ranges from 50 to 300 microns within the dental alveolus. Thus, we achieve a high resolution magnification needed for microsurgical procedures, such as regenerated alveolar site control and vital bone perfusion evaluation. In this image on the left, we can see the schematic representation of a super immersion endoscopy technique. We can see that in order to perform an endoscopic navigation within the bone cavity, the endoscope support must be at short distance from the bone surface, or practically in contact with it. Besides, we need a drainage or suction system. On B, we can see the activity of microcapillaries when the irrigation system is not activated. And on C, we can appreciate the occlusion of the small blood vessels when the irrigation system is being activated. With this method, an intraoperative microscopic bone visualization can be achieved in real time. In this case, we use a 2.7 millimeter optics, endoscopic optic from the entrance of the dental alveolus, in which radicular remains are visible in the apical portion. With the simultaneous use of a Heidelberg type microelevator under endoscopic view, it is possible to observe to precisely place the instrument in the periodontal space in order to mobilize the remaining apical root. After the root extraction, we can see a radicular disc extend in the apical portion adhered to the bone wall, probably in the apical portion, the most apical portion. Then we use a Lucas surgical curettage to remove the granular tissue under endoscopic control. This way, we are able to remove pathological tissues and root fragments within the dental socket with precision, aided by magnified visualization. This is very important to ensure the implant placement in a socket which is free of pathological tissues, and this way avoiding failures during the osseointegration period. In a study conducted by the Nobuto group, we can appreciate that the size of Folman canals has a caliber ranging between 100 to 300 microns, similar to the human. The periodontal ligament plexus is really a microcapillary net. Due to this anatomic condition, the Folman foramen must have at least 50 microns diameters. This brief description of the microvascular anatomy of the dental socket will give us a better understanding when performing an endoscopic visualization with an immersion technique after an atraumatic extraction. In this clinical example, I have performed a flap extraction using the Venex system of the German company Messenger, also called a vertical extraction system that you may have used as well. In this type of extractor avoids the use of forceps and has good indicator for its application in the atraumatic extraction of anterior teeth. For example, it slowly disrupts the periodontal ligament fibers until the extraction of the root is achieved. This process takes about 4 or 5 minutes. In this case, we have performed an immersion endoscopy immediately after the extraction of the root previous to the curettage of the socket. By using this high magnification technique, we can appreciate the presence of blood plexus and the activity of the vascular microcapillaries, arterioles of venules that emerge from a vascular canal at least 50 microns diameter. You can also observe some areas or vascular zones of 1,000 to probably 2,000 microns of extension in the apical portion that are probably ankylotic zones inside the alveolar socket. In this clinical case, we must take into account that we have not performed a flap. Thus, the small socket blood vessel might come from major vessel from the medullary bone or the periosteum, whose function is to irrigate the periodontal ligaments fibers. It's impressionant to see here the application of the super-immersion endoscopy technique in vivo. It's really an interesting technique, and in my group, we use this procedure as routine in my clinical practice. Okay, the next. Now, briefly, I will describe some examples about this technique in the routine practice. In this clinical case, I want to demonstrate how support endoscopy can be an aiding tool too. In the first place, be able to visualize radicular fragments in the depth of the sockets under hard unification. And in second place, it allows us to assist the precise positioning of a specific instrument. In this case, we use a hidden beam root type elevator to remove a small apical root fragment in the relation of contact with the alveolar inferior nerve. All of this is a minimally invasive manner. Okay, in this case, in this study from Beno, is very interesting the introduction of the concept of minimally invasive vertical extraction technique through the Venex system. Has permitted an innovative approach for the removal of the teeth of root remains up to a certain degree of complexity. The limitation of the system are characterized by the insufficient retention of the fixation screw and also by fractures that tends to occur during the extrusion with the instrument. Here, sorry. Okay, here I wanted to share with you the clinical sequence step of a minimal invasive vertical tooth extraction in the 2.4 position. In this case, we carry out a combination of the vertical root extraction prior to a section with a piezo-surgery in the most buccal area of the root, similar to socket shield technique. In this endoscopic video, you can appreciate the progressive extrusion of the first premolar root and how the sharp fibers rupture progressively. It is easy to notice that once the root remains is removed through the Venex system, The root buccal shield is completely in place. You can see here after the extrusion of the root here. It is practically unnecessary to use additional instruments to modify this shield of the dentin. Here we can observe the sequence of the minimal invasive extractor procedure step by step and the endoscopic examination on the internal alveolar perspective, completely integrate using a super endoscopy technique. This is done by positioning the endoscopy support on the most occlusal portion of the alveoli. In fact, in this video, we can observe here the endoscopic examination immediately after the root extraction. In this case, we can use normally an endoscope of 2.7 millimeter in diameter to permit in a global perspective of the internal vision of the alveolar walls. Here. I use piezosurgical equipment in my daily practice. It is interesting study by the Blues group. You can see a variety of recommended piezosurgical tips for different phases of syndesmotomy with and without teeth. Besides, the author recommended several vibrating osteotomy tips for extraction socket of different shapes and diameters. Normally, I use a cylindrical piezosurgical tips immediately after the extraction. This tip is very useful to perform a curettage the apical portion of the alveolus, especially when it's associated with an apical lesion. In this clinical case, after the extraction of the tooth in the 2.4 position, I am performing the Alveoli Curettage with the same piezosurgical cylindrical and diamond tips. I go through the apical portion of the alveoli, touching the bone wall. After that, I perform mucoperiosteal tunneling using pressure decollators. Sorry. Ah. Sorry. Okay. Here, I perform a last examination through the endoscope to visualize the integrity of the buccal and wall, and it's possible to appreciate a small fracture feature, but without compromising the periosteum. Then I place a preconformed collagen membrane through the tunnel, and I seal the occlusal portion of the alveolus above with a biomaterial, in this case, a particulate allograft, before the placement of the final suture. 6 months after the procedure, I carry out the implant placement on the site, and prior to the implantation, I perform a visualization through super immersion endoscopy, in which it's possible to appreciate a high vascularization of the bone site. Once I place the implant, it is possible to visualize a good integration of the peri-implant bone tissue through a diagnosis implantoscopy. In conclusion, intraoperative magnification methods allow to perform more precise dental extraction techniques, locating the instrument in direct sight and maneuvered in a more accurate and safe way. Super endoscopy and super immersion endoscopy techniques allow us to observe relevant anatomical structure in real time during routine surgical procedures, and can be a complement to dry D imagology. And finally, different dental extraction techniques can be performed depending on a specific anatomical indication and the type of implant rehabilitation, of course. Of these regards, having a good variety of equipment, for example, microscope or an endoscope on simultaneous use, the both, and micro instruments should be the gold standard to perform predictable procedures in oral and implant microsurgery. Thank you very much for your time and for the live invitation on this mini conference. Thank you very much.
Thank you, Dr. Beltran. That was very interesting. You know, it looks more like you're doing an ACL repair rather than doing work on dentistry.
Thank you very much, David.
There's definitely, I mean, as you showed, there's obviously benefits to the endoscopic surgery, but the equipment is expensive. Do the benefits outweigh the cost?
This is a good question, David. The cost is very discutable at this point, but there are many options for very companies in Europe or in America. That of course, Car Store is a expensive company for equipment for other pieces. So in specific, the cost of the optic is high. Normally, it's $2,000 or $3,000 per optic, but it's necessary to use in a good manner. But I believe that in the future, the other companies can develop a new device, new equipment, new approach with other equipment. In this moment, I am working with other German companies, small companies, and we intend to perform other alternative for less expensive of the stores. But for in the other fields, for example, for medical fields, you can see that is a routine. It's a clinical routine in a variety of specialties in the medicine. You can see that the different gastroenterology or otorhinolaryngology and others, the specialists use normally endoscope, and the expensive cost, the expensive of the equipment is not a theme, but it's a good question, David, and I believe that in the future is a good sharing for the companies.
One other question. Dr. Paul Rosen with Mark Reynolds a few years back published a study where they did an endoscopic examination of the Schneiderian membrane after transcrustal sinus augmentation, and they said the incidence of perforation is much higher. Have you used this system for doing sinus augmentation yet?
Yes. They are in specific 3 different approach. A lateral approach, the name is a technique from Professor Engelke, was described in 22. The number is subanthroscopic lateral basal sinus floor augmentation technique. It's possible to perform a small wall in the lateral part of the sinus, and you can make a tunnel, a lateral basal tunnel in direction to the augmentation site. In the other perspective that is many interesting for me and for my group is the intracrystal approach. And naturally, this conference in other contexts is in socket preservation and extraction techniques. But in intracrystal technique, it's very interesting to use this technique as intermittent control. Yeah, in an intermittent control manner, we can use the optic of 2.7 millimeter or 1.9 millimeter. You can make a control intermittent during the drilling or during the vet preparation, and it's possible to observe. There are other devices. Professor Nageli had published a new implant with a specific intraapical canals, and it's possible to introduce the endoscope, a mini endoscope, in the implant for control or application of medicaments in this area. But normally we use an intracrystal control manner with optic from of 2.7 or 1.9 millimeter of diameter. But it's a good application in intracrystal elevation or summer technique.
Well, thank you. I don't see any other questions, but I think you're right. You know, when you look at the usage of endoscopic approaches in other surgical disciplines, I mean, you wouldn't do an open ACL repair now. I mean, the only way to do it is endoscopy. And for a lot of GI surgery and gallbladder appendectomy, the preferred now is endoscopically, unless of course there's some reason that prevents it. So this truly is an emerging technique, and I look forward to watching its use expand in dentistry. So thank you very much for your presentation today, and without further ado, we'll bring up our next speaker, Dr. Juan Mosquito. Thank you again, Dr. That was an excellent presentation, very interesting.
Yes, thank you very much, David. Bye.